Hi, everyone. Thank you for joining us today. Whether you're on Facebook or YouTube, we'd love to hear who you are and where you're joining us from. And we're so excited to have you here this evening to learn a little bit more about speech development in the cranium for someone with cleft lip and cleft palate. My name is Stephanie Paul, and I am the Executive Director for MyFace, and I am so pleased to welcome you to our program today. This web education program is designed for families of children with craniofacial differences, caregivers, and healthcare providers. I would like to thank the J.M. McDonald Foundation for funding this important program and acknowledge their appreciation for the critical need to provide educational programs like this one for families of children impacted by craniofacial differences. MyFace has a long history of providing access to comprehensive medical and dental care, along with education and direct patient services, providing the way for better patient outcomes. At the heart of our approach are three pillars of support. First, through our grant funding, we deliver quality, comprehensive craniofacial care to ensure that patients can receive medical and dental care regardless of their ability to pay. Second, through our range of direct services, MyFace seeks to educate patients, families, and healthcare providers through programs like this Transforming Lives webinar series and topic-driven workshops. We also strive to raise public awareness about craniofacial differences through our Wonder Project school assemblies and our monthly podcast, My Face, My Story, Voices from the Craniofacial Community, where individuals can share their stories, be seen, and be heard. My Face is here to bring together the craniofacial community and help transform the lives of children and adults living with facial differences. We believe everyone deserves the chance to thrive and live the best life possible. And now on to our program. Our presenters today are Lauren Beckett, speech language pathologist and instructor at the Child Development and Rehabilitation Center at Oregon Health and Science University in Portland, Oregon. And joining her is Meg Lico, speech language pathologist at the MyFace Center for Craniofacial Care at NYU Langone Health in New York City. We will also hear from Meg Edwards, a parent of a child with a craniofacial diagnosis, who will be sharing her experience with speech and language development. After the presentation, we will open the program for questions from participants. As you think of questions for our speakers, please enter those questions into the chat on your screen during the program. It is now my pleasure to turn the presentation over to Meg Lico.
Hi, Stephanie. Thank you so much for that introduction. I know that Lauren and I are really excited to be here with MyFace to talk with you all a little bit about speech and language development for children with a cleft lip and or a palate. So just some financial disclosures. We are both full-time salaried employees, as Stephanie mentioned, of our respective hospitals. We are both certified speech language pathologists. And some of the things we're hoping you're going to gain from today's presentation, we want to review general milestones related to early speech and language development, and then specifically talk about how having a cleft palate might impact that speech and language development. And lastly, we really want to provide families who are listening with strategies to encourage speech and language development over time. So I'm going to talk to you today a little bit about cleft palate and cleft lip as related to speech and language before the palate is actually repaired. So on average, and it's different for every child, but we usually say between 9 and 12 months is when the palate is repaired. And then Lauren's going to speak a little bit more about strategies and what to do after the palate has been repaired. So in the child's first year, a lot of parents ask me, okay, what can I do immediately to get going with the speech and language? How do I develop it? And I think that's an amazing question, but we also want to acknowledge all the other things that are going on during your child's first year of life. You've just given birth to this beautiful child, and we want you to also enjoy it. And so one of the first things that I talk about is interaction and attachment. And one of the important things, we know skin to skin contact is really crucial for bonding. We also want to encourage play skills. So things like peekaboo. Additionally, the airway is really important, especially for children who might have something like Pierrot-Benz sequence or Beckwith-Wiedemann in addition to their diagnosis of a cleft palate. So you might want to check in with ENT. Your craniofacial team should, already be providing those referrals for you, but airway is really crucial in the first year of life. And then I won't spend too much time on this because this could be an entirely separate webinar because there's so much good information out there about this. But we also really want to focus in the first year of life on hearing and audiology. So we know that some children with cleft palate do not pass the universal newborn hearing screening, which is essentially a pass-fail hearing screen that is administered in the hospital when your child is born. And so it's really crucial to follow up with ENT and audiology in the child's first year of life. They might need ear tubes, which will help to mitigate the presence of what we call otitis media with effusion, which is essentially a fancy term for fluid in the ear. Doesn't necessarily mean the fluid is infected, but there is fluid in the ear, and so the ear tubes help to mitigate that issue. And they did find in 1998, they did a study of 50 children with cleft palate, and they did find that those children, 97% of those children's ears actually had otitis media with effusion. Perfect. So now we're going to talk a little bit about feeding as well. So each feeding team, each craniofacial team is different when it comes to who handles the feeding on the team. For my team specifically, we have an amazing nurse practitioner, Pat, an amazing registered dietitian, Deb, and then myself, and we all collaborate on different feeding goals. You see the Dr. Brown's specialty needs valve up to the top right there, which we find works for a lot of our children who have a cleft lip and palate. And this is really important in the first year of life, in addition to speech and language, because you're preparing for these surgeries and you need to have your child gain weight in order to go under anesthesia. And so this is a really huge part of what we do in that first year. And then the last thing I would say, nasoalveolar molding is a common practice for many craniofacial clinics across the country and across the world. You'll see that bottom right picture is a picture that, a mold that has been created at our orthodontics team, our NYU team. And we utilize that in the first 3-ish months if the child has a cleft lip and palate in order to help with pre-surgical molding. If you want more information on that, I'm sure there's information on the internet. I won't go too far into that either. But just overall, I wanted to mention all of these things because you're preparing for a lot in order to get ready for surgery. And we want to acknowledge that speech and language are super important in the first year of life, but you're also, as parents, balancing a lot of different things. And so we want to help you as speech pathologists to kind of balance all of it and feel supported as you go through this journey with your child. So just to get down to the nitty-gritty of the specific language goals that we want to see in the first year of life, and I'll talk a little bit about where you can find more of this on the internet if you need to reference it again. But between 0 and 3 months of age, we really want to start to see those cute vowel sounds. So what we call cooing and gooing. So ooh, ah, really cute laughing, smiling, any kind of vocal play sounds, playing with saliva. We love to see that in the first few months. We also want to be able to know that the child can turn their head to look for a parent, right? We want to know that they recognize that their caregiver, they can't see their caregiver, and so they're going to look for their caregiver to meet their needs. We also want them to turn their head towards a sound, which again, ENT and audiology will be involved to make sure that hearing is adequate. And we want them to be able to maintain some visual attention, not for too long, but enough of an eye gaze in order to kind of, attend to what's going on in the room. And then once you hit 4 to 6 months of age, that's when it starts to get really exciting because you might see some signs of reduplicated babbling. That's my baby cousin on the bottom right, and it was really fun to watch him develop with his reduplicated babbling, which I will describe a little bit more depth in just a minute. We also see that children begin crying in different ways to have different needs met, which crying in and of itself is not fun, but it's really exciting when you see that the children are able to adapt their sounds and their crying in order to indicate a certain need. So for example, when they're hungry versus when they're tired. And we also would like them to respond to their name either by turning their head or making eye contact. So to jump a little bit more into babbling, specifically really 6 months is kind of right when it starts, but it can be anywhere between 6 and 12 months is generally when we want to see some babbling occur. And we call this canonical babbling. So canonical meaning a consonant and a vowel, right? Consonant vowel strings. So you'll start out with reduplicated babbling, which is kind of, if you think of the word duplication, right? It's just kind of over and over, same consonant and vowel string. So ma, 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 ma. And then as the child begins to progress in their development, you're going to start to see what we call variegated babbling, which has different consonants and maybe different vowels as well. So mama lana would be a good example. And then it's okay if your child does not hit this milestone right at 12 months, but just on average, we usually see the first meaningful word around approximately 12 months of age. We don't expect these words to sound perfect by any means, but what's more important is that they're attaching either a caregiver or an object or something, whatever the word is about, with that word, and they're understanding it, versus with babbling, it's more just about making fun sounds with your mouth. So one of the resources I love to draw parents to online when I'm not able to speak with them directly is online. There's the Center for Disease Control and Prevention Developmental Milestones Tracker. So you can actually they have an app on your phone if you want to download the app, or you can just go to their website and Google CDC developmental milestones. And you can see here that you can select the age, so 2 months, 4 months, 6 months, and it will give you all of the milestones, not even just for speech and language, but also gross motor, fine motor, cognition, and so forth, so that you can kind of just generally follow your child's development and kind of see if it's, in general, again, one skill won't make or break their development if they're missing one specific skill. But in general, we want to see that their development is on track with these milestones. And then we are certified with ASHA, known as the American Speech and Hearing Association, and they also have wonderful resources on their website. So you can see here this page specifically to kind of exactly the same thing that CDC does, except this is more specific to speech, language, and hearing development. Okay, so we've gone over some of the general milestones that we want to see in the first year of life, but I'm sure many of you want to know, how does that differ for my child who might have a cleft palate and or a cleft lip? If there is just a cleft lip only and no palate, we usually see fairly typical development over the years. However, 1 in 5 children still need speech therapy, regardless of if there's a cleft lip or palate. So I think it's really important to continue to be monitored over time, have your child be monitored over time by the team speech language pathologist. If there's a cleft palate, though, sometimes we have seen in the research that there can be a slight delay in babbling for children with cleft palate. And you'll see there that one study that was done in 2001, where a little over half of babies who had a cleft palate reached that consonant vowel babbling stage by about 9 months of age, whereas children without a cleft palate, usually the majority of them are able to hit that canonical babbling stage by 9 months. We also see more glottal sounds for babies who have a cleft palate. So a glottal sound being right here at the level of your vocal folds or your voice box. So whereas children who did not have a cleft palate did not use as many glottal sounds. So one of the biggest things that we want to talk about as well is, what sounds can my child make before the palate repair and what sounds can't they make? And I spend a lot of time at my center speaking about this with families. We kind of have a separate one-on-one meeting and we talk through all of this because we want to make sure that we're capitalizing on their strengths. So children who have a cleft palate can't physically make certain sounds when they have an open palate, because for a lot of sounds in the English language, we really need a lot of this, what we call intraoral pressure. So intraoral literally meaning inside the mouth. So if you think about a balloon blowing up, right, when you want to blow up a balloon, if you were to poke a hole in the balloon before you even tried to blow it up, it just would never work, right? And so that's kind of the analogy I like to give when I'm talking with families, right? And so that means that between 6 months, which is when babbling can start to occur usually, and the time of your child's palate repair, which remember is, again, on average, not for everyone, but on average between 9 and 12 months, that's like a 3 to 6 month window that we have to figure out, okay, what are we going to work on? What are we going to, capitalize on here so that the child we're not expecting the child to do something that he or she physically cannot do yet. So I have created this worksheet for my families, and thanks to MyFace, it's now going to be available to you all on their website. And so this actually goes through in depth exactly what sounds work and exactly which sounds don't work in terms of eliciting sounds for babbling prior to the palate being repaired. Once the palate's repaired, it's a totally different ballgame, and Lauren will, talk with you a little bit more about that. But we're going to focus on what we call low pressure sounds, and we won't focus on high pressure or the sounds that require that intraoral pressure. And I'm going to show you a visual in just a minute that Lauren created that kind of helps to break it down. But you'll see here, I've given some examples of babbling strings to kind of target with your child until palate's repaired, and also some functional words you can model. And you can read this more in depth again on the MyFace website. So this is the visual I was just mentioning. So you'll see here, when you have this opening at the top, we don't see the palate here. This is kind of general anatomy, lateral view, right? So that yellow box, P, B, T, D, K, G, that box is the box where all of those sounds, unfortunately, require a lot of intraoral pressure. And so basically, we don't focus as much on those sounds until the palate's repaired, just because then we're kind of expecting the child to have to really strain to try and make those sounds. And then what ends up happening is sometimes they'll develop what we call compensatory errors. So they'll make the sound somewhere else. And then as speech therapists, we have to undo it later. But we want to develop their language just like any other child, right? So these blue boxes, M, N, N, G, W, Y, R, L, and H, those are sounds that don't require a high amount of pressure in the mouth and therefore can be achieved before the palate is repaired. So that, again, you'll see it from the prior slide in the babbling worksheet. You'll see those specific sounds that are in the blue boxes as to what we want to capitalize on. Those are the sounds we really want to push until palate is repaired. And so my last slide, we want to encourage language development. So keeping the specific phonemes and specific sounds in mind, you can utilize these strategies to encourage language development, even past a year of age, but I like to bring them up. So I'm just going to briefly run through all of them. And certainly if you have any questions specifically, you can write them in the chat. One of the strategies we love is called a +1 routine. So maybe at 12 months of age, if your child's first word is bird, right? Or maybe it's mama, because unfortunately they're not able to say dada yet until palate's repaired. Then you're going to add in just one extra word. We want to keep the language pretty simple so that the child is able, hopefully one day, to imitate it, right? If we have a really long sentence, it's going to be hard for them to imitate that. And then the next strategy we talk about is the 3-to-1 rule. So a lot of times, one of the biggest things that I loved when I was going through my program, when I was becoming certified, was one of my professors told me, teach, don't test. And I think as parents and therapists, we have this kind of pattern where we want to test the child. So what color is that? What is that? Tell me what that is. What's that in the book? And we realized that by providing more statements, that's actually helping model the language better than asking them a question. We want to teach them all the concepts first, with the hope that down the road, when they are asked those questions, it will be easier for them. I also love verbal routines. Ready, set, go is one of my favorites. Now, keep in mind, ready, set, go, the child will not be able to say go until after the palate is repaired, right? Because that G is a high pressure sound. But we can model it still right before. We can begin to set the standard for the first year. And so singing songs. So I love singing a song during hand washing, things like that. If they go up and down, making a song out of that, if they like to be picked up by the parent. So you want to utilize the same verbal routines throughout the day so that they can begin to anticipate the language and kind of pair the language with a certain action. And then we also want to narrate your day. So as the mom who on the top right corner is shopping, right? So she's going shopping. And if you think about it, and I myself would do the same thing, I would probably be listening to music, or I would just not even be talking, right? I'm just looking at the different foods. But if you have your baby with you, it would be awesome to really narrate, oh, look, orange carrots. All right, put in the cart. Because you want to attach a sound to any action you're doing throughout the day. I almost say to parents like ad nauseum. You might be sick of and tired of doing this by the end of the day, but it's really going to help your child. And then the last couple strategies. So the first is communicative temptations. So for example, any kind of opportunity that you can create to have to make a sound in order to get the desired toy or food. So for example, putting their favorite toy in a jar or a box where they have to knock, 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 or say "oh" for open. Those are some really good ways to kind of literally tempt the child to make a sound to ask for your assistance. We want to repeat everything over and over and over again. I think we've touched on that. We want to provide increased wait time for the child. So we want to definitely, for example, when you say ready, set, go, and you've taught it, when it comes time for you to try to elicit it from your child, you would say ready, set, really long wait time, almost to the point where it feels a little awkward, and then see if they can make any kind of sound. Then you want to really reward them if you do hear any kind of sound. And lastly, we want to utilize toys that help elicit language development. These are two of my favorite toys in the bottom right. A lot of people think that toys that make noise or sounds or music, there's nothing wrong with those, but a lot of them think, oh, well, that's going to help my child make all these sounds. And while there is something to be said for that, we actually, as speech pathologists, prefer toys that don't make sound because it requires the child to attach the sound to that toy. And so you can ask your team speech pathologist if they have any recommendations. I'm sure they'll have a billion, as I do and as Lauren does. And with that, I am going to turn it over to Lauren Beckett, who's going to talk to you about speech and language development after palate repair. Thank you.
Yeah, thanks, Meg. She did a lovely job of setting the stage for us as far as what speech and language development looks like before palate repair. So now we're going to go into speech and language development after palate repair. So immediately after palate repair, you might notice that your child has a little bit of decreased babbling. We call this the recovery period, and that can last usually somewhere between 2 to 6 weeks after the palate repair surgery. And it's usually related to the child having a little bit of swelling or discomfort in their mouth and just kind of adjusting to this new intact palate that they have. After that recovery period, then we're going to notice that our child is kind of getting back to the normal amount of vocal play or sounds that they were making beforehand. And hopefully they're kind of making some new sounds, learning to explore this new palette that they have. And this is when we want to start to work on developing those oral pressure sounds that Meg mentioned. And in this time, I just want to mention that it's normal for our kids with cleft palates to still have a bit of a preference for the nasal or low pressure sounds, or even those throat sounds that they might have been producing before their palate surgery, because that's what they have the most practice with. Following up on Meg's slide that was talking about language goals in the first year of life, these are just some more language skills that we're hopefully going to see develop over the second year of life. So in the 12 to 18 month age range, as Meg said, we're hoping to hear those first words start to emerge, and we might hear our kids mixing real words and what we call jargon. Jargon is kind of what families call baby talk, or when your baby is making lots of sounds, putting them together as if they're having a conversation, but you might not have any idea what they're saying. And that's a totally normal part of speech development. During this time, we're also going to notice that our kids are starting to imitate sounds and words a bit more. And then as far as their understanding of language, they might start to identify some body parts. If you say, "Where's your toes?" they might pick up their feet or glance down towards their toes. And they're starting to get better at following simple directions like "come here," maybe with some gestural cues. And then they're also beginning to identify words with pictures or objects. So if you are looking at a book and you say, "Where's the dog?" they might be able to identify the dog in the pictures. And then in the 18 to 24 month age range, we're going to see more frequent babbling and picking up more new words. During this time, we also usually start to hear our kids combine words together. So you might hear "mommy help" or "more milk," where they're starting to put those single words together. And during this time, we're also going to start hearing a greater variety of sounds in their productions. And hopefully, we'll start to see that they're more successful with a little bit longer directions. Go get your shoes, bring them back to me. So looking at the anatomy picture again that Meg showed you, the way that I like to explain this to families is now that the palate has been repaired, our child is able to close off that nasal cavity from their oral cavity. And the way that they do that is they activate the muscles in their palate here, and their palate has to raise up and touch the back wall of the throat to close off that little channel that's circled in red. And that's how they build up that interoral pressure that Meg was talking about in order to produce all of the sounds that are highlighted in yellow there. So just because your child's cleft palate has been repaired, it doesn't automatically mean that they're going to begin producing these oral pressure sounds right away. So because of the limitations with their speech development prior to palate repair, we know that even after palate repair, sometimes our kids with histories of clefts will continue to show a preference for those nasal or low pressure sounds that they were able to make before surgery. They might also show a preference for those throat sounds or glottal stop sounds like Meg mentioned. And the glottal stop sound I also like to mention is the consonant sound that's in the word uh-oh. So often it's a sound that kids do make when they're younger, but we want to make sure that they are not learning to use that glottal stop sound to replace other sounds that we want them to be developing. And then we also know that our kids with clefts sometimes are more likely to produce sounds like the K or G sound that are made in the back of the mouth. So after palate repair, what we really want to focus on is getting our child to learn how to activate their palate muscles to make those oral pressure sounds. And the first oral pressure sounds that develop are P, B, T, D, K, and G. We also want to discourage them from using those throat sounds, the glottal stop sound, or any kind of harsh growling or grunting sound. So if your child is using any of those sounds, we want to kind of ignore them. We don't want to repeat it back or laugh or have our child repeat it really frequently. We often say if your child is making one of those growling sounds, for a specific word, instead of repeating it back how they said it, you can repeat back the correct word and you can kind of emphasize the sound that they're leaving off. Or in this example, I also talked about if your child makes a growling sound for a car as they're driving a car, you could teach them a different sound to make instead. So maybe you say, "Oh, I see your car. Mine says beep, beep." Another thing that I often tell parents, and this one is really hard even for me as a speech therapist, is to avoid saying uh-oh as much as possible because it does have that glottal stop sound in it. So instead of uh-oh, I like to tell families to say, oh no, oops, or whoops. All of those have sounds that your child is going to continue to use in more words as they get older. So those are good sounds to encourage. And then lastly, I just wanted to say that we really want to praise our child for any attempts at imitating words or sounds. So we can do that by getting really excited anytime they try to imitate what we're saying. Even if what they say doesn't sound exactly like the sound or word that you said, you can tell them, thanks for using your voice, or I saw how you moved your lips just like me, to encourage them to keep repeating and playing around with their voice. So some specific strategies to work on the pressure sounds are what we're going to go over next. So Meg and I both like to start with the P and B sounds first as our first pressure sounds to work on because they're made with the lips, P and B. So they're really visual, they're easy for kids to see, and they can kind of watch our lips and begin to figure out how to make those sounds. So to encourage that, we can do things like vocal play, blowing raspberries with our lips, or lip smacking, or popping. We can also think of words that are associated with toys or books in the house that start with those P and B sounds, and we can emphasize them as we say them. Here's your baby, baby. Other things that we can do are sit face to face with our children so they can see our mouth and our face as we're talking. That helps to just make them more aware of where our sounds are coming from. We can also point to our lips, or we can touch our baby's lips to show them, hey, I want you to focus right here. Look at what my lips are doing, and then touch their lips and see if they try to imitate. You can do a similar thing by holding your baby up next to you in a mirror so they can see their own face and your face side by side as you're talking. Another way to draw your child's attention up to your mouth is if you're playing with a toy, you can hold that toy up next to your face so that your child is looking at the toy, and then they can quickly glance at your face so they don't feel like they're missing out on the toy by looking at your face. So these are some examples of different ways that Meg and I would work on those P and B sounds in a therapy session, or things that we would recommend to families at home. So we can pick out certain activities and create a word with it that starts with one of those P or B sounds, and just say it really repetitively, like Meg said. So with bubbles, we might say pop, pop, pop every single time we pop one of those bubbles. You can think of foods that your child likes to eat. Maybe instead of calling them crackers, we can start calling them puffs, so we can emphasize that p at the beginning. Meg talked a little bit about making verbal routines like ready, set, go, where we say the same phrase every time we play with a toy. And we could do the same thing with waving goodbye. So every time we're done with a toy, we're going to wave and say bye-bye. So our child gets lots of practice saying those B sounds. I'm going to skip over a few of these points that just talk about other ways, or other words that have those P and B sounds. The last one I'll mention on here is nursery rhymes can be a really great way to work on the pressure sounds. Some of our favorites are Baby Bumblebee or Wheels on the Bus. Those are really repetitive nursery rhymes that have a lot of those B sounds in them. Next, we have just a really quick video. This is an example of a patient of mine who's working on the word banana, and he doesn't quite have his pressure job of
Banana. Okay. Banana. Banana. Banana.
So I love that video because you can also hear the sibling in the background who's also modeling the sound for our little patient here. And as you could hear, the patient was kind of saying like, anana. He was leaving off that B at the beginning. So as his parent was saying it back, she was really emphasizing banana to draw his attention to that first sound. Okay, so in this slide, we're going to talk about the role of speech therapy. So research has shown us that between 50 to 70% of children with cleft palate will need some type of speech therapy by preschool age. And the earlier we address concerns, the easier they are to correct. So speech therapy has been shown to increase the number of different sounds children make, the accuracy of their sounds, and reduce the number of glottal stops or throat sounds that our children with clefts are making. And as a caregiver, it's really important for you to be involved in the therapy process. So we really want you to be in the room during the speech session, and we want you to be asking your therapist to explain what they're working on or ideas for how we can practice those same skills at home. And my last slide here is just to explain to you the role of the cleft palate speech pathologist that you might see on your cleft palate team once or twice a year. So even if your child is getting speech therapy at home, we still want to see them during their cleft palate team visits. And the reason for that is that we're checking in on their speech and language development, but we're also focused a little bit more on that anatomy piece and assessing how well the muscles in the palate are working for speech development. And we're also listening to see if your child is developing any of those compensatory errors, which Meg kind of briefly mentioned, are errors where the child might produce more sounds down in the throat or by pushing air up into the nose. And if they do have those sounds, or if we notice a little bit of a language delay, those team visits would be when we would help refer you to speech therapy and get you connected to those services. And lastly, I just wanted to say if you have any questions or concerns about your child's speech or language development, you can always reach out to the team speech pathologist or to Meg and I, and we're happy to direct you to where you need to go or answer your questions for you. So that concludes my portion. Next, I'm going to turn it over to Meg Edwards to talk about her experience as a parent.
Thank you so much, Lauren. Hi, I'm Meg Edwards. I'm the mother of Matthew Edwards, and I'm so excited to share with you my story in terms of speech and language with Matt. Here is a couple pictures of Matt from when he was first born. He had a very wide cleft, and he did have a very large cleft palate opening as well. Here he is now, and he just recently became a big brother, but these are all pictures post his palate surgery. So when I was 12 weeks pregnant with Matt, my husband called me and he said, I'm going to a charity event tonight in the city for my company. I will be home late. I said, okay, no problem. Have fun. When he came home that night, it was May of 2019. He said, I went to a My Face event and it was wonderful. They were honoring different surgeons in the cleft palate world. And I said, oh, wow, that's so interesting. Well, 4 weeks later, we got our sonogram at the hospital and we found out Matt was going to be born with a cleft lip and cleft palate. Well, it totally changed our world and it was really, really hard for us. But we were thankful that we had already had this connection to My Face and NYU and a family that had gone through what we were going to go through in December of 2019. So that was kind of how we initially got connected with NYU and My Face. So I knew that finding a support team and getting all of our key players in place prior to Matt being born was going to be something really important. So we met with NYU and thankfully we loved them and we went with their surgeon and the speech team and the ENT, everyone that's part of the NYU team are all part of Matt's team. And it's just been an amazing experience for us and we're just so thankful to have found them. As far as working with speech. So when Matt was 3 months old is when we were advised by NYU to apply for early intervention in New York City. So this is a process that was new to us. So we were guided throughout the whole way with NYU. So you apply through the state and you got a mandate of 3 sessions a week with Matt. Well, the pandemic had just started. It was March of 2020. So we started doing everything virtual. So we had virtual therapy for Matt 3 times a week. Then after his palate was repaired when he was a year old, we knew that we would really rev up the speech therapy component. So we talked with Meg Lico at NYU, and she helped me find a private speech pathologist as well as a group kind of speech and language class that was being hosted in Central Park in New York City. So we did all three of those things, and that was really, really, really crucial to our speech and language for Matt and our language development. One of the things that our surgeon said to us when we first met him that really, really stuck with me was that there's certain things that as a parent with a cleft kid, you really control and you really can play an important role in. And that was the speech and language. That yes, you might have a provider coming in 3 times a week or, a couple times a week, but you're with your child the majority of the time, or your caregiver or his father, and you really have the impact on their speech and language. So we really took that and ran with it. And not only did we do private speech, group speech, EI speech, we also had our caregivers, which are our grandparents, we had them get trained by our therapist in speech and language so that everyone was on board. And every couple months, I would make these little goal charts and hang them on our fridge and over where Matt's toys were. And they would be the goals that we were working on. So everyone knew. Even I would forget sometimes, oh, what are we supposed to be working on this week with Matt? Okay, and then I'd look up to my sheet and I know exactly what we needed to do. I still email Meg. We had a meeting a couple of weeks ago and I asked her to send me milestones of what I need to be working on with Matt. I still do my monthly goals for him, and he's 2 already. So it was really, really, really important that I had everyone on board, even, grandparents, friends that would come over. Okay, this is what if you're going to play with Matt, you got to make sure that you're following all these goals that we're working on. So that was really good. As far as encouraging language, some of the other things that were really important to me was that we didn't do TV until he was 2. So really, Matt has not had TV and iPad and technology. We really, really, really wanted it to be us engaging with him and hearing and having him watch our mouths and hearing us talk and not using TV and iPad. So I thought that was something as well that really, really helped us. Some challenges we had, it definitely was hard after the palate was repaired. Matt took a long time to really produce those palate sounds. And it was really, really stressful for me because I knew there was a certain time frame that would that it would take in order to hear those sounds. And it took a lot longer than we expected. And it was really, really, really hard to wait. I felt like we were doing everything possible we could to make sure that he was going to be able to say those sounds. And it just took a lot longer. And it just was, the wait was really hard for us as a family. And so the outcomes today. So now Matt is 2. He had his 2nd birthday in December. And he is saying over 200 words. He's combining 3 to 5 words. He can repeat, any word that we say or any, couple words that we say together. Every day he's saying something new to us. He's really meeting milestones of a typical developing 2-year-old that isn't cleft affected. Even now I heard Lauren and Meg talk a lot about nursery rhymes and singing. Well, Matt has a little sister, and we did a lot of open shut them with him when he was younger, and he sings that to his sister now. He loves all those nursery songs that we thought we were just singing and repeat until we were blue in the face. Well, it's really paid off because he's singing them now, and he's singing them to his sister. So that's really awesome to see as well. One of the things that our speech therapist has always advised us on was making speech therapy fun. So we always try and play games. We always use mealtime and bath time. Matt loves being read to. So, we use mealtime where he's able to sit across from us and watch our mouths and watch the sounds that we're making. We always read and do different language activities with him during mealtime and bath time because he's sitting in the bath and you're down crouching over the bathtub. He can really see your mouth. So we have everyone on board for that. Even grandparents are, know that during meal times we read and we talk with Matt. And so it's great. Some of Matt's speech related challenges, like I said, it took time for the palate sounds to come in. And now, Matt is doing so well with his milestones and his language development, he is having a hard time with the S and the F sounds, which are nasal sounds. I know that Lauren and Meg talked about that. So he is having some nasal sounds now. I have to say the impact of speech therapy on Matt's future has made all the difference. The fact that the NYU therapist, Meg, has always been in contact with, we moved recently. And so she then connected with the therapists that are in Connecticut now with us. So having everyone as a team and everyone working towards Matt's goals has made all the difference. And starting him at 3 months with therapy has just, I really, truly believe in the early intervention that we use with Matt is what has made him so successful today. We're true believers in speech therapy, and we just really love that we're so on board with, the team, and we really feel a part of Matt's speech development. Thank you so much, and I'm happy to answer any questions. Thank you so much.
Thank you, Meg. Thank you so much for sharing your story. And I want to thank Lauren and Meg for their incredible information. We're going to take a few minutes to do some Q&A. We do have some questions coming in. And if you have a question, we ask you to put your question in the live chat on your Facebook or your YouTube stream. And for everybody to benefit from these questions, we want to make sure that they're general in nature, and our speakers will answer those questions general in nature. So let's start with the first question. This is a clarifying question I'd like to ask Lauren. We don't want to have them practice the sounds, example P and B, until after the palate repair, so they aren't learning to speak them incorrectly. Or should we try it before? If you could clarify that.
Yeah, so I like to tell families that it's totally okay to work on the P and B sounds and to model those for your child so they're seeing how you make them and they're hearing them. And it's okay if your child tries to imitate. The main thing is just knowing that your child is not going to be able to build up the pressure for those sounds. So if they try to say maybe baby, it might sound like Mimi. And that's okay. So as long as we're not penalizing our child, we can continue to say, I like how you're using your voice, or thanks for trying, to encourage them to keep talking.
Great, thank you. Meg, did you want to add anything to that?
I think Lauren did a great job. I always say, we don't want to not have you talk about a banana if your child loves a banana. We just really don't want them to develop these negative compensatory patterns that as speech pathologists, we have to undo later. And if you're not sure which, if you think, oh, well, I think the lip closure is good here and I think it's pretty natural, Meg Edwards has actually done this to me before where she sent me videos where she's like, or is it really like a compensatory error? Which one is it? You can talk to your cleft palate speech pathologist on your team to get that clarification so that you're promoting the nasal sounds, the liquid and the glides, those blue box sounds that we talked about in the diagram, but also encourage functional words that maybe your child really likes, like banana.
Great. Thanks, Meg. And to that point of finding the speech therapist, we have a question, Lauren. How can I find a speech therapist near me who has a lot of experience with cleft lip and palate? Because, there could be somebody who's in the middle of the country who may not be able to have that resource. What's the best way for somebody to find a resource?
Absolutely. So I think the first step that I usually recommend is that they reach out to the speech therapist on the cleft palate team that they're seen through. Now, if you haven't been established with a team yet, or maybe you haven't been introduced to the speech therapist on your cleft palate team, you can certainly reach out to Meg or I, and we can try to help connect you with someone. The cleft palate professional community is a pretty tight-knit community, and we have a lot of connections. And I know when I have families who move across the country, I make it my mission to find a speech therapist that I'm going to be able to hand them off to, kind of like Meg Edwards was saying, to be able to tell that therapist, okay, this is what we're working on. Here's where I would suggest taking things next.
I just wanted to say something on finding a therapist with cleft background. So the therapist that I went private with didn't have cleft background, but when I talked to Meg about using that therapist, I realized she's the expert in cleft. I'm never going to find someone that has as much expertise as she does, but having someone that's a great therapist that then can communicate and always be in contact with Meg if she has cleft specific questions. So I chose someone that necessarily didn't have a cleft background because I knew Meg was my point of support when it came to the cleft, when it came to speech.
Great. And Meg, we have a question for you. How many times a week does Matt go to speech?
So he now has 2 times, but we at the beginning we had 3 times a week.
Okay, terrific. And let me ask a question. Meg was talking quite a bit about toys and special tactics and strategies. You talked a little bit about that, Meg, but did you have something that was your favorite strategy in working with Matt?
I think the singing. I think the songs definitely. And actually what Meg Lico said, we didn't use the noise toys. That was something that was advised to us. Don't use toy. You know, we actually use the Love Every play kits, and that was really helpful because all of those toys are kind of open-ended play, and they're not noisy, colorful kind of toys.
Okay, great. We have a comment here that somebody would like you to share your monthly charts. I don't know if that's a resource that we can maybe think about providing.
Yeah, I would love
to. So I'd love to turn to Meg Lico and ask a question that I think is really important. English is not our family's primary language. Would it be best to find a speech therapist who can work with our child in our native language? And second to that, if a child speaks 2 languages, English and native, even if they have a cleft palate, how to deal with that?
Yeah, that's a great question. I get that question a lot in our prenatal conversations because a lot of the families are bilingual here in New York. And some families, even too, working with families who speak Yiddish, for example, the child learns Yiddish the first few years of life. And then once they hit schooling age, then they start to learn English. So I tell them that is absolutely okay. There's no reason, just because your child has a cleft lip or palate, it does not mean that you should not teach your child another language or teach them your native language. Either or. Just the presence of a cleft palate alone does not automatically mean that your child, is intellectually, delayed in any way. And so we want to be able to encourage the language development of the family and of the home. In terms of the, should I get my, a therapist who speaks my language? Yes, if you are a monolingual speaking, meaning one language in the household speaking, for example, Spanish family, it is best to have a Spanish speaking speech pathologist who's available. And just like Meg Edwards said, that speech pathologist can communicate with the team SLP. So if they have questions specifically related to the cleft palate, maybe they're super great with bilingual therapy, and now they just want to get some extra information on that, we can communicate with them. And I just want to add, if you haven't linked up with a speech pathologist on your cleft team yet, or if you haven't found a cleft team, also on the ACPA website, the American Cleft Palate Association, there is a directory. So the MyFace Center for Craniofacial Care is on there. I believe Lauren's is on there as well. And you, as to be an accredited ACPA team, you have to have a speech language pathologist on your team. So you can utilize that to link up, and then they can from there refer you to a speech language pathologist who speaks your language. And you can teach them both languages, one language. The only other thing I'll add is that you do want to apply the same rules to your native language that you would apply. So the same things Lauren and I discussed with those intraoral pressure sounds in the mouth, that's still going to apply to other languages.
Terrific. And we do also have a link to the ACPA directory on the myface.org site. So you can come directly to the myface.org and find that information. So here's a question, and I'll open this to anybody, I guess, in the panel here. Is it typical having speech therapy 2 to 3 times a week?
I I can jump in and start with that one. I would say that depends on a few things. It depends on kind of what's going on with your particular child, what the speech concerns are, and then it also depends on your access to therapy. So, in a lot of the settings that I've worked in, which are hospital settings, we see a large number of patients. And so, usually, we would see patients maybe once a week. So, if you're if you're being seen through private speech therapy or through early intervention, you might have other options available to you. And I also think that Meg Edwards mentioned that they were getting speech therapy from multiple providers, it sounded like, at the same time. And so those 2 to 3 sessions a week might not have been with one provider, but might have been once a week through early intervention and then once a week through the hospital. And Meg Edwards, if you want to chime in and add more there, you can.
So we used early intervention in New York City, and we did 2 sessions a week through that, and then 1 session a week through a private therapist. That's just what we felt was best for Matt. That was just and we were living in New York City, so we really had access to a ton of different, therapy options. So.
Great, thank you. So unfortunately, I only have time for one more question. And I'll again open it to anybody who wants to answer this. How long will my child need speech therapy for? If we start speech therapy when she's really young, will she still need that when she gets to be school age? And add on to that is, how early should we start speech therapy?
I can jump in. So in terms of the first question, there is some research to suggest, as Lauren had kind of mentioned, that about 50 to 70% of children who have a cleft palate will need speech therapy, usually up until the age of 5. It depends on your child. It's very child dependent in terms of how long your child will need speech therapy. As we've all stated between Meg, Lauren, and myself, the earlier the better, right? We want to capitalize on this as early as possible so that when your child begins to learn more academic things like reading and math, they're not having to be pulled out in the school system. Obviously, there's nothing wrong with that. And even my brother got speech therapy. He didn't even have a cleft palate, and he got speech through the school. But the earlier that we can try to mitigate these errors, the better. And another reason to try and mitigate them early is if you think about your brain and how these neurons kind of connect, the more we practice the incorrect way of saying something, the harder it will be to undo it. So if we do it at a really young age where those patterns haven't been strengthened and formed yet, and try to, reverse whatever patterns they currently have, or strengthen new patterns like with Matt, with Meg's son, then that's going to give us such a better advantage moving forward. And then in terms of how early should you start speech therapy, I think it depends again on the child. Some of our kids need to start feeding therapy first, for example, with the speech pathologist, because a lot of speech pathologists do the feeding therapy through early intervention, and then they switch to the speech. Some kids feed totally fine with a cleft lip and palate, so then they might start the speech pieces a little earlier. So it's just child dependent. I think the key here is talking with your craniofacial speech pathologist on your team and getting their advice, because they can go over milestones with you and talk through your child's specific journey and then give you the best advice.
Terrific. Thank you so much. Well, Meg and Lauren, thank you so much for all this wonderful information. And Meg, thank you for sharing your story and your journey with Matt. And we're so glad to see how happy and wonderful you guys are all doing. I do apologize that we could not get to every single question tonight. But if you have additional questions, please write to MyFace at info@myface.org. Again, that's info@myface.org, and we will answer your questions for sure. Because craniofacial differences can impact the body and spirit so significantly, MyFace provides important direct services such as access to patient and family support groups. All of them are now virtual. We have topic-driven workshops and online programs that serve to educate and entertain. These programs offer guidance and resources and a supportive environment for everyone who participates. MyFace aims to empower the spirit and build strength and let families across the country know that they are never alone. For more information about our programs and services, we offer, please visit us at myface.org. I also want to let you know that we'll be hosting the next My Face, My Story podcast with an episode entitled Love is in the Air, Navigating Relationships and Intimacy with a Facial Difference, which will be held on Wednesday, February 9th at 6 p.m. Eastern Time. To register for that program, visit myface.org/mystory. And we also want you to look out for an email to register for our next Transforming Lives webinar, which will be entitled The Adventures of Moving On, Transition for Care for Individuals with Cleft and Other Craniofacial Differences, which is going to cover navigating that transition from being a teenager to adult care for those in the craniofacial community. At MyFace, we strive to provide the most helpful and informative resources. To help us do so, we ask that you take a few moments to complete our brief survey by visiting myface.org/speech webinar and let us know your thoughts. We've also provided this information in the reminder email we sent you and will be in an email you will receive after this program, so we encourage you to complete the survey. Again, thank you for sharing your time with us today and have a wonderful evening.